College Dublin team. Just a brief introduction. Unfortunately, there's only 3 of us here today, as 2 of the girls, both Clara, who is a medical student, and Jodie, who's a nursing student, are on the front line doing placements. So we have Manvi with us, who's a medical student, myself, who's a social work student, and Natasha, who's a physiotherapy student. So first of all, I just want to introduce why we chose to operate from a person-centred model within our team. So the Hftc is moving towards a model of service, which is increasingly user-led, as set out in the 2018 document. Interprofessional working is increasingly becoming viewed as a central component and best practice in the delivery of all healthcare. As a team, we came across one immediate barrier in our work with Roya, that being the challenge of communicating with her. We agreed as a team that we must source a translator, as maintaining contact with her husband, being the translator, is not best practice and poses potential ethical challenges. The most common language in Afghanistan is Dari, and translators are readily available. We discussed the need to coordinate this as a team to make it flow smoothly for Roya. To further embrace user-led principles, our team discussed the importance of underlying our practice with anti-racist practice and ensuring that we are culturally competent prior to and during our work with Roya.
So as a medical student, for medical intervention, I feel the main aim is to alleviate her central pelvic pain, then to inform the mother and the family the risk, the possible interventions to improve her glycemic control, as well as to help ease the distress the mother has about the well-being of her unborn child. So in terms of patient education, so for the implications and complications of GDM on the mother and the fetus would include, for example, the mother has a risk of type 2 diabetes in the first 5 years post-mortem. And for the fetus, there's an example of maybe fetal osmotic diuresis, which could lead to an increase of fluid in the amniotic sac in the mother. Then importance of also informing the patient of blood glucose monitoring, then diet and lifestyle changes. So in terms of the diet, so having a individualized diet plan from a dietitian. So this helps with the appropriate glycemic control. Then in terms of breastfeeding is crucial as well, because skin-to-skin contact should be allowed, as well as early and frequent breastfeeding to avoid any neonatal hypoglycemia and to stimulate lactation. And it's also seen to reduce the risk of obesity and type 2 diabetes in later life in mothers who have had GDM. Then there's also the need for mother and fetus surveillance. So basically having an ultrasound during the 3rd trimester to assess the fetus well-being as well as growth. And since her HbA1c level is less than 53, we don't need to test for any congenital abnormalities. Then in terms of labor and delivery, vaginal delivery is the most preferred one, especially over here, the metabolic control is essential. So having a glucose level of around 47. In terms of the pharmacological intervention, insulin therapy is the primary first-line treatment. Then they can also be given oral hypoglycemic agents. So an example basically being metformin, and this could be preferred over insulin since there is less weight gain, better satisfaction, and even more compliance. And since she didn't have any folic acid prior to conception, it is important to give any supplements during a pregnancy because it can help to reduce any major birth defects. So in terms of the nursing intervention, it could be in terms of explaining means of self-management to the patient. So monitoring like I mentioned, monitoring the glucose levels, following the recommended physiotherapy plan, as well as the individualized diet plan. Then also helping to provide any appropriate education required for the self-management for her diabetes. Then also explaining how to use a self-injection pen. Then also it's important to provide referral to the public health nurse and the community midwife, as she seems to have limited access to the required facilities, and to also ensure she's linked with a GP and has a connection with pharmacy in a close proximity in order to ensure there's relevant prescriptions sent there since she isn't fluent in English.
So from a physio and an OT perspective, I think it might be most beneficial to do a joint assessment, together, just in terms of reducing the number of contacts that the patient is going to have as an outpatient. Again, we'll talk about this again later, but the communication piece is going to be so important because there's going to be a lot of education and advice, particularly around the American College of Sports Medicine guidelines about exercise, the role of exercise for mental health and maternal health, and precautions around exercise and pregnancy. So I suppose other things that we need to be conscious about are a home exercise program and a walking plan with onward referrals to community-based groups, such as maternal walking groups or swim classes as appropriate. In addition to that, in a more focused, from a physio perspective, we probably need to investigate a little bit more the SIJ pain, which is obviously very common in pregnancy, given the hormonal changes, and some education and reassurance around that, as well as investigating the aggregates and the easing factors, and encouraging easing factors and establishing, I suppose, a SIN, which is the severity, intensity, and nature of that pain, as well as investigating a bit more about the pins and needles in her hands, and is that related to the GDM, and again investigating aggregates and eases for that. And then from a more specified OT perspective, I think there would be some kind of assessment in terms of transfers, getting in and out of bed, going to the bathroom, using chairs, and her ADLs, her paddles, personal activities of daily living, and her daddles, daily activities of daily living, and then a kitchen assessment, checking how she is managing in her kitchen at home. And are there investigating any home adaptations that she might need in terms of like rails on the stairs or grab rails in the house as appropriate. But those, of course, are more long-term adaptations, and I suppose we would need to investigate if they're appropriate and necessary. Additional resources in terms of gloves to help with the pins and needles and sensation in her hands as well. So that's kind of that from us as a pair.
Thanks for that, Tash. So Roy's situation is one which clearly needs a social work intervention, so I'd like to thank the team for sending me on that referral. As is seen in the slide, using the Bronfenbrenner's ecological approach, there are various levels of intervention needed in her case. So to address the individual micro needs of Roy's situation, I refer her on to One Family Free Counselling, who can offer Roya counselling supports free of charge, especially around the area of grief of unborn children. A further psychosocial assessment would be needed to establish if Roya's children need additional supports at this time. I will aid Roya in accessing all appropriate state supports, so this would be more on the macro level, and this would include accessing medical card, child's benefit, diet supplement scheme, and any other state supports which prove necessary. It's also appropriate in this case to investigate Roya's housing situation. Should she be availing of Dublin City Council housing aid, it's important to help her link with maintenance to get her heating fixed, which would be of paramount importance to the whole team. Alternatively, I'd explore the possibility of joining the housing list and or accessing HAP for Roya and her family. I would also provide emotional support and would ensure the team are practicing in an anti-oppressive manner throughout our work with Roya.
So I guess, if we're going to discuss key takeaways from this case and from our interactions with Roya, communication is going to be a huge piece. So working all together as well is incredibly important. We all have really important points in terms of supporting Roya, providing appropriately timed care to her. I suppose one of the main aims medically is to improve her glycemic control and to address her distress and her anxiety, and providing support for Roya and her children and her husband in the best way that we can. And again, making every contact count in terms of reinforcing the importance of exercise while pregnant.